Thanks for joining us today. We're talking again about secondary prevention with aspirin. We've got some world's experts here. We're going to first talk about the high risk groups, people like the diabetics, patients who are obese. Talk a little bit about aspirin dosing in those folks, and we're going to have Neha Pagidipati joining us today, and we'll hit that first. Then we'll move on to the guideline statement, particularly in people who have had a recent PCI, and we're having Jacqueline Tamis-Holland join us and talk about that. And then we'll wrap up with Dominick Angiolillo talking about some recent advances, looking at newer formulations of aspirin. Good. Looks like we have a pretty good audience at this point. So Neha, let's start with you. Do you want to use your slides, or do you want Meg to put the slides up and drive the slides? How do you want to do it?
I can share my screen if that works for you.
That's great.
Are you able to see my screen in presenter mode?
We can see it, Neha. Thank you.
Perfect. Well, thank you so much. And Dr. Gibson, thank you so much for having me here. As you mentioned, I'm Neha Pagidipati, and I am a preventive cardiologist at Duke University. I have the pleasure of directing the Duke Cardiometabolic Prevention Program. And really, in both clinically and in my research, my focus is on how to manage cardiovascular and cardiometabolic and renal risk of patients who have metabolic disease like obesity and diabetes. And so the vast majority of my patients have either or both of those syndromes. And therefore, I think a lot about how we manage their overall risk, and aspirin comes into play quite a bit. So really what I'd like to do is just to go through a little bit of what the data is in these populations for aspirin, and what my approach as kind of a basic clinical cardiologist would be.
Great.
These are my disclosures. And so where I'd like to start is just a quick reminder, right? Because there's been so much confusion about aspirin, especially recently, and in primary versus secondary prevention. And this is just a reminder that what I'm mostly going to focus on is secondary prevention, where we do feel like it's pretty clear that these patients should be on aspirin therapy, especially right after acute coronary syndrome or revascularization, but even into the longer term. And so this is, this has been promoted by the guidelines as a class 1A indication. And a lot of this data stems from the antithrombotic trialist collaboration. But what we'll focus on, as I mentioned, is in patients with obesity and in diabetes. And we'll start looking at patients with obesity. And really where this comes into play is because many studies have found that obesity can affect both the pharmacokinetics and the pharmacodynamics of aspirin therapy. And what I mean by that is the pharmacokinetics means the ability to achieve an adequate concentration of the drug. And in pharmacodynamics, we mean the ability to achieve its end goal, which is to inhibit platelet function. And what we know, and this is from a nice review in 2018, is that in patients with obesity, both of those things are impaired. So there's a decreased absorption and bioavailability of aspirin in general in patients with obesity. And there's also alterations in baseline platelet reactivity and platelet turnover that makes it harder for aspirin to kind of do its job. And interestingly,
Neha, why is there decreased absorption? That's interesting.
Yeah, and I will tell you that I don't have the exact reason for why there appears to be decreased absorption. Now, we will look in just a minute at the different formulations, because obviously absorption and bioavailability is also very different by the type of aspirin, and that appears to be different by weight as well. Now, what are the exact reasons for why that's different? I have to say that I'm not sure, and it seems like most people aren't sure. There seem to be a lot of hand waving around like inflammatory milieu and, different things related to also potentially like dysglycemia may also be affecting it. And we'll get into that with diabetes as well. That's a good question. So this is actually one of the most often cited studies, I would say, in this space. And this was a meta-analysis published in The Lancet in 2018. And it looked at 10 trials, and this was mostly of primary prevention. And we will talk a little bit about secondary here, but this is mostly of primary prevention, a large number of patients. It was a patient level analysis, over 117,000 patients. And what they did is they looked at the kind of the potential interaction between weight and aspirin effectiveness or responsiveness. And what they showed is that at low doses of aspirin, again, we're not talking about the different formulations, just the dose here. At low doses of aspirin, events were prevented in patients at low body weight, so at patients who were less than 70 kilos, but not in patients who were higher than 70 kilos, which was the vast majority of patients. However, if you took the higher doses of aspirin, those doses were only effective in patients who were more than 70 kilos, which raises the question, should we be treating patients of higher body weight with larger doses of aspirin? And really, they found that there were no differences in this relationship between men and women and people with or without diabetes. And they did look at a few secondary prevention trials, and it looked somewhat similar as well. But the thing I want to point out here is that none of these trials were designed to look at this interaction. And so really anything that we take away from this has to be hypothesis generating. But we already know, now this gets at the formulation question, Dr. Gibson, that you were kind of getting to. So we already know that from a lot of studies, and this is one example, that enteric-coated aspirin has lower bioavailability to begin with, whether or not we're talking about a patient with obesity. And this is another off-cited study that was published in Stroke in 2006. And they took 71 healthy volunteers. Okay, so these are healthy volunteers, and they used a crossover design where each volunteer took 2 different aspirin preparations, and they looked at aspirin and astaxanthin, which is basically like aspirin dipyridamole, and they looked at enteric-coated aspirin. And then they looked at the degree of treatment failure and treatment inhibition as measured by serum thromboxane levels. And basically what they showed, if you look here, you can see that over half the patients, again, that's overall in a healthy population, over half the patients did not get complete inhibition with enteric-coated aspirin, again, indicating that there is something to do with this enteric-coated formulation that decreases the aspirin responsiveness. But what's really interesting is that there was a relationship with weight, and this is what we were getting at. So what you can see here is that as weight increases, this is the line for the, both 2 lines for the decreased responsiveness, inhibition, and decreased reactivity. There's increased kind of lack of response as weight increases. And really what they found was that a 10 kilo or 22-pound weight increase was associated with a doubling of risk of treatment failure for enteric-coated aspirin. So it does seem like enteric-coated aspirin it differentially has a harder time kind of reaching its goal in patients with higher weight. And so this led an expert consensus.
So, Neha, that's amazing. I mean, if you're about 200 pounds, you faced about a 75% failure to achieve that level of inhibition that you had there. Is that right?
That's what this is showing. Again, so here's what the theme is going to be here. And you can see my takeaway here. There are a lot of small studies. There's a lot of small studies with very variable and heterogeneous populations. And how can we apply all of these small studies to a large population of patients that we see? It's remarkably difficult. So what I take away from this, as you can see here, is there's a lot of very hypothesis generating, thought provoking information that's coming out, but really what we need is a proper outcomes trial. Now, whether or not that'll ever be done, I don't know, but what we really need before we start necessarily changing around the dosing and the frequency of aspirin is to understand better how it will actually affect these patients. But I will say that this was an expert consensus document from an ESC working group in 2018. And they said it is reasonable, you can see here, it is reasonable to double the daily dose or shorten the dosing interval to twice daily in patients with a BMI of greater than or equal to 40. So as we're talking, I really want to hear from others what you do in your own practices and what you're seeing others do as well. I will say that another possibility to address this is not just to change the dose and the frequency, but to change the formulation. And so this was a study that was published by Deepak Bhatt and others in JACC in 2020. And they compared basically aspirin response by weight with 2 formulations. One was the enteric-coated aspirin, and another is another formulation called PL-ASA that is a lipid-coated aspirin that theoretically has more bioavailability. And what they showed here was that indeed, in patients with obesity, that you were able to get higher amounts of aspirin response up until higher doses, up until higher weights with this lipid formulation, indicating a higher bioavailability up to higher weights with this formulation compared with enteric-coated aspirin. So it may not just be about frequency and about dosing, but it may be about formulation as well.
Fascinating.
And then I'll just finish up with diabetes, which is in some ways somewhat of a similar story, that patients with diabetes may be independent of obesity, but a lot of the data is from patients who have both diabetes and obesity, that there's different levels of platelet reactivity, and the biology of the platelet is different in patients with diabetes than in those without, and that may affect the effectiveness and the response rates to aspirin. So this is actually from an excellent review. I will toot the horn of Guillaume, who is Marquis Ravel, who was a former DCRI fellow, who is now the senior author of this review. It's excellent. And they nicely summarize many smaller studies that suggest that patients with diabetes have incomplete and non-sustained platelet inhibition with once daily aspirin. And so there's this thought that maybe BID dosing in patients with diabetes would be helpful, but we don't have data for that yet. There is an ongoing trial, amazingly. There's an ongoing trial called the Andaman trial that will assess the impact of BID aspirin dosing on patients with acute coronary syndrome and type 2 diabetes. But what this review nicely outlines is basically that in patients with diabetes, there's increased baseline platelet reactivity. Again, it was like, was a bit of finger, hand waving around milieu of dysglycemia and kind of increased inflammation. There's increased platelet turnover. And so basically the timing of dose may be really important. And then of course, most of these patients have obesity as well. And as we talked about, there are issues with bioavailability in those patients. And then the other thing to keep in mind here that was brought up in this review is that some of the erratic absorption of enteric-coated aspirin may be exacerbated in patients who have some gastroparesis. And as we know, a lot of patients with diabetes will have kind of subclinical gastroparesis that we may not even fully recognize. So again, Dr. Bott did a really interesting study published in JACC in 2017, where he and others took 40 patients with obesity and exposed them to the high dose of aspirin, 325 milligrams, but different formulations. There was plain aspirin, there was the same lipid-coated formulation, and there was enteric-coated aspirin. And what you can see here is just look at the rate of non-responsiveness, of unresponsiveness to enteric-coated aspirin. Over half the patients were considered to be to have incomplete response to enteric-coated aspirin, whereas that was much smaller with plain aspirin and with the lipid-coated formulation. And here, if you're looking at time to responsiveness, again, it takes a lot longer for enteric-coated aspirin to reach that kind of therapeutic level, where it's very similar between plain aspirin and this lipid formulation. So, what do I take away from all this? Gosh, what I take away from it is that I already knew that patients with diabetes and aspirin were at high risk for cardiovascular disease. Now I think that how I treat them with aspirin is even more complicated than I thought before. But I don't yet know that we have enough data to justify changing around our dosing or our frequency at this point. But there are ongoing studies, and so I'm eager to see what those show.
Neha, that was spectacular. Is there any data from Adaptable that sheds light on this? I mean, have the folks at Duke looked at this weight issue?
Yeah, that's a great question. I am not aware of yet an analysis looking by weight in Adaptable, though I may be wrong about that. I do believe they looked at any difference in effect between, as people know, Adaptable looked at aspirin 81 milligrams versus 325 milligrams in kind of a real world pragmatic study among secondary prevention patients. And I believe they looked at the effect by diabetes status, and there was no difference. But again, it was a negative trial to begin with. And as we know, a lot of the patients on 325 of aspirin, a large proportion of them actually switched over because it was an unblinded study. They switched over to aspirin 81. But in the analysis they did do on diabetes, there was no difference.
When you were doing your hand waving, all I could see were the pseudopods of, the angry platelets, making
This is my cytokine storm inflammatory milieu.
Yeah. So Dominick, do you have any ideas, why do obese patients have poor absorption of aspirin?
No, I guess, as Neha mentioned, there's probably not a specific reason. There are probably multiple reasons. Now, many of our obese patients also have diabetes. We know there's a component of gastroparesis. So you add that together with the increased platelet turnover rate, it's obviously a perfect cocktail for less bioavailability. I just want to to add something to it because yeah, excellent presentation. One thing to keep in mind that aspirin is circulating for a very, very limited period of time after oral intake. It's around 20, 30 minutes. So if that aspirin does not interact with the COX-1 enzyme, then it's game over, right? And since there is this limited lifespan of circulating plasmatic levels of aspirin, that's the whole issue with the increased platelet turnover rates that once you have these newly introduced platelets, it takes very, very little thromboxane to be released to have incomplete inhibition. So that's one of the problems that we do have with diabetic platelets and the rationale behind the twice daily regimen. And, our group was one of the first to actually publish a study looking at the PD effects of that. And clearly there's a difference. Now, do I recommend it in my patients on a routine basis? The answer is no. I look forward to the study being conducted in France, as Neha alluded to, the Adamant study, to look at the outcomes. But it makes sense. So I do have some patients, however, who may, for whatever reason, still be with the 325 milligrams of aspirin. To those patients, I will say, well, instead of taking that, maybe take the 81 milligram twice daily, but we don't have any outcomes data to this extent.
Kind of amazing. We have a drug that's been around for a couple thousand years, and we don't know the right dose. And, we're still figuring it all out. It's just kind of amazing. Well, Jacqueline, talk to us about the guidelines. You're going to kind of hone in on the guidelines in those patients who've had a PCI. You were on the guidelines committee. Could you drive us through your slides?
Sure. Can you guys see my screen?
I can. That was the smoothest handoff I've seen in a long time.
Okay, I was ready for you. That's why. So
Great.
Hi, everybody, and so much, Michael, for inviting me to be here. And it's really my pleasure to be able to talk to you a little bit about the guidelines and the aspirin recommendations for the guidelines. I apologize for my looks. I just got out of a 3-hour case and I have the N95 facial features. So sorry. I personally don't have any disclosures relevant to this talk. But as Mike already alluded to, I had the privilege of being one of the writing committee members for the 2021 REVAS guidelines. And so we did have a certain section related to aspirin and other antiplatelet agents in the acute setting and in the long-term setting. So I will be discussing those guidelines today. So what I'm going to do is, because there's a lot to talk about, and obviously I think it's more the meat is in the discussion rather than my presentation. So what I'm going to do is focus on aspirin use after PCI, which are what the recommendations are currently using, looking at, and the duration of DAPT after PCI. I'm going to review the guideline recommendations for triple therapy after PCI, and I'll highlight some unanswered questions related to aspirin therapy in my mind. There is a section in the REVAS guidelines on aspirin use after CABG, and of course, these guidelines don't cover the topics of aspirin use after just AMI without PCI or without revascularization. So what are the recommendations for aspirin use after PCI? So they give a class 1 recommendation that patients who are undergoing PCI get a loading dose of aspirin followed by daily dosing. This is recommended to reduce ischemic events. And interestingly, if you think about it, this is just aspirin per se, not necessarily a P2Y12 inhibitor. It's really based on, when you go back, and this is a little historical interest slide, when you go back, it really is based on data from way, way back when they used aspirin during PCI, and they demonstrated that the use of no aspirin was associated with much more thrombus burden compared to the use of aspirin at a more maximal dose, in which there was really essentially no thrombus burden during the PCI. Now, fast forward, now we're doing stents, we're doing drug-eluting stents, but nobody's ever changed that. Since we used aspirin initially, it's shown to be a benefit. Even when we introduced stents and used P2Y12 inhibitors, we're still using the aspirin during the PCI and after the PCI for these original reasons. So it's interesting because it remains there.
In 1987, if you go back to that, Jacqueline, this is not a PowerPoint slide. This is when you had to go to the basement to that guy and he would hand draw, the slide and prepare it for you in the AV department. So that's how old this is, 1987. Yeah.
it's very, I love that sort of historical stuff, but
Yeah.
anyway. So the guidelines do give some sort of outline for dosing. They're not clear recommendations, but this is the usual dose that they recommend. So they say a loading dose of 162 to 325 milligrams orally and chewing to achieve faster action, and then a maintenance dose of 75 to 100 milligrams daily. Now, again, this is after PCI, or after PCI. So the interesting thing is we give those dosing, but as you sort of alluded to, Neha already alluded to, it's interesting because we're not quite sure the optimal dose for patients on getting aspirin after PCI. And I'm just going to sort of take you through the data that we have. And really the only large randomized, well, not the only, but the largest randomized trial data is from the current OASIS, which enrolled close to 25,000 patients, and they enrolled them in patients with ACS, and they randomized them in a 2x2 factorial design to a high dose of clopidogrel twice a day versus a low dose. And sorry, this is just going forward. And they randomized them to a high dose of aspirin versus a low dose of aspirin. And they looked at patients overall and those patients who were getting PCI. And lo and behold, there was absolutely no difference in the primary endpoint, which was CV death, MI, or stroke at 30 days in the group of patients with higher versus lower dose aspirin. And additionally, there was no difference in bleeding with high versus low dose aspirin.
But I think there was a higher rate of GI bleeding, as I recall, with high dose aspirin. That's one of the findings.
Got it. That I'm not aware of. Thanks for clarifying that. But interestingly, speaking of the subgroup analysis, when you do look at the subgroup analysis, there is no interaction by subgroup for weight or diabetes. So it's interesting because this was a negative trial, but there didn't seem to be any interaction in terms of preferential benefit in those less than or greater than. They used, I think, a cutoff of 60 kilos, and patients with diabetes or no diabetes. In the aspirin dosing in ACS, the Translate ACS study, this wasn't the primary hypothesis. This was just sort of a subgroup looking at different doses of aspirin. And in this study, you can see that any bark bleeding and lower bark bleeding was significantly higher in the group of patients who had, was significantly lower in the group of patients who had the lower dose aspirin. And overall, there was no difference in ischemic events between the low dose versus the high dose. Additionally, when you look at data from the Plato trial, so it's very interesting because the Plato trial, after the Plato trial was published, there was some delay before it was FDA approved, and it had to do with the fact that there seemed to be a relative differential outcome effect with the patients enrolled in the Plato trial, the benefit of ticagrelor in patients in the United States and Canada versus those elsewhere who were enrolled elsewhere. And when you looked at it further, it seems to be that more patients in the United States and Canada got the higher dose of aspirin. So sort of when they did an adjusted analysis, they demonstrated, I'm so sorry, this should not be timed, but they demonstrated that there was an interaction with ticagrelor and outcome by dose. So the high dose aspirin and ticagrelor group did the worst in terms of the primary endpoint.
Did we ever understand that, Jacqueline? Did we ever get to the bottom of it?
No, I'm not really sure, and maybe Dominick can say better. I'm not really sure why that was, because it was interesting because it was really the ischemic endpoint. It wasn't necessarily a bleeding endpoint, but it was the higher dose aspirin that did worse with ticagrelor compared to the other doses of aspirin.
Time for hand waving again, or maybe Dominick, any explanation?
No, we looked into this very, very carefully, and the short answer is we did not come up with one. And it was an interesting exercise even to write that manuscript. One of the thought processes that originally was the higher dose of aspirin and greater interaction with the prostaglandins, but then this was also looked, as you recall, in the Triton trial, that outcome was not observed. A story that many people do not know. There was even a thought process that there was an issue with systematic distribution of the actual drug in the United States, saying that maybe the patients who received thought to have received ticagrelor actually received clopidogrel and vice versa, but that was not the case either because we went back to look at the stored samples, as if you may recall. So the bottom line that there was not a definitive explanation to this. There were also additional studies looking if there could have been a problem of interaction between the drug and the actual P2Y12 receptor based on the aspirin dose, and that was not confirmed either. So I think the fair answer is we do not know.
And Americans tend to be larger than Europeans. So you would have thought, if there was a there, is bigger is better, and, a higher dose would be better in larger people, you might have seen it here, but it went the wrong way.
Exactly. I was thinking the same thing when Neha was presenting her presentation, that the reverse results in the North American population would be contrary to what you would think, because we tend to be more overweight.
Yeah.
Benefit from.
Well, talk to us about duration of DAPT.
Yeah, so this is a very interesting topic. I want to stress that there are 2016 recommendations, and the way we do in guidelines is that if something hasn't changed, we review the data, and if something hasn't changed, we sort of refer out to the prior guideline. So in the future, we're going to sort of hopefully have modular chunks that get sort of integrated into a guideline, but the recommendations we give in the 2021 guidelines related to duration of DAPT pertain to anything that's new or anything that has changed, but anything that remained the same you refer to the 2016. So looking at the 2016 recommendations for duration of DAPT, they say they have two separate sort of groups of recommendations. Those are after PCI for ACS, and then after PCI for stable ischemic heart disease. And in patients with PCI for ACS, the recommendation is a class 1 recommendation to give 12 months of DAPT. And then it's a class 2B recommendation to say that if they've tolerated DAPT and they don't have a bleeding complication, you might consider prolonging the DAPT beyond 12 months. And it's a class 2B recommendation as well that if they didn't tolerate the DAPT or they had some sort of higher risk of bleeding, then you might consider stopping the DAPT earlier than 12 months, i.e. after 6 months. When you look at stable ischemic heart disease, it's very similar, but with a shorter duration. So they say 6 months of duration of DAPT, and then they say that you might want to consider going beyond 6 months if there's no bleeding risk or they're tolerated it well, and you might want to consider as a 2B to stop it earlier after 3 months after the PCI in those patients who are higher bleeding risk or who you're concerned about bleeding. And this is based on a lot of data. Well, the DAPT trial was really one of the pivotal trials that they used to base this data on. And the DAPT trial showed that using a longer duration of DAPT, i.e. more than 12 months, so up to 36 months compared to 12 months, that there was the primary endpoint showed a significantly lower stent thrombosis with a longer duration of DAPT. And there were two co-primary endpoints. So the second was major adverse events, and that was also significantly lower with the DAPT therapy compared to placebo. But interestingly, in this trial and all the data we see consistently, there was higher incidence of gustral severe or moderate bleeding and BARC 2, 3, or 5 bleeding. So all of the data, we have to balance the patient's ischemic risk with the patient's risk for bleeding. And that's just always something we have to be cognizant of in all of our patients, and the guidelines reflect this. When you look at the systematic reviews performed for the DAPT guidelines, you can see that the pooled data of 3 months showed actually no difference in mortality, no really borderline, but no difference in major hemorrhage, although there was this sort of a borderline benefit to shorter duration of DAPT and less hemorrhage. And they showed no difference in stent thrombosis regardless of the duration of DAPT. When you look at the DAPT duration for 6 to 12 months versus, 12 months versus 48 months, this is 6 to 12, but it's 12 versus 18 to 48. You can see that there's no difference in mortality, but with longer durations of DAPT, overall, you see a higher hemorrhage, and these are pooled data of all of the longer duration of DAPT trials, and you see a lower rate of stent thrombosis. So again, you have to balance that bleeding versus that ischemic risk. And this is DAPT, meaning you stop after 12 months or after 6 months or whatever your cutoff is and change to aspirin. And so now there's a new kid on the block, and that's what we discuss in our 2021 guideline recommendations, because of all of the other stuff remain the same with the exception of this. And the new kid on the block is a shorter duration of DAPT, but instead of stopping the P2Y12 inhibitor, they stop the aspirin. So there's been numerous studies looking at 1 to 3 months of DAPT followed by P2Y12 monotherapy. And it's a class 2A to say that this is a reasonable option to reduce the risk of bleeding. And so let's look at this data. So I'm just going to take one of the many trials that looked at this, and this is the Twilight trial. And all of these trials were designed to look at bleeding as a primary endpoint. And some of them, such as the Twilight, looked at non-inferiority at ischemic events. So in the Twilight trial, they randomized, I guess that's 7,000, 8,000 patients, I think it was. Somebody can tell me better. And they looked at the primary endpoint, which is BARC 2, 3, or 5 bleeding, with a shorter duration of DAPT followed by P2Y12 monotherapy compared to standard DAPT therapy. You can see there's a significantly lower bleeding at 12 months. But when they looked at ischemic events, again, these aren't powered to look at ischemic events, but they looked at they were powered for non-inferiority, and they showed that there was absolutely no difference in ischemic events between the shorter, it was non-inferior in terms of ischemic events between the two durations of DAPT.
But the audience should know that we, in Twilight, we gave people a few months, 3 months of DAPT before we did that randomization, right? And I don't want people to think we stopped right at the time of the PCI.
No, absolutely. I said a shorter duration of DAPT of 3 months in Twilight, followed by P2Y12 monotherapy, and all of the trials looked at between 1 and 3 months.
I only say that, Jacqueline, because my own fellows, I was senior author on the paper, and my own fellows thought it meant you could not use DAPT, right? You know, for the first 3 months. That's not what it meant. So I'm just making sure my own fellows understand it.
Yeah, absolutely. No, that's a very good point. And I'm just going to go back again to the guideline. And you can see that it's 1 to 3 months of shorter duration of DAPT followed by P2Y12 monotherapy. It does not say to stop the aspirin after the PCI is done.
Right.
So this pooled data, again, all of these studies looked at bleeding as a primary outcome. There's a lower rate of bleeding with a shorter duration of DAPT, and there doesn't seem to be a signal of harm in terms of MACE. If anything, MACE is slightly reduced, although not significantly reduced, with the shorter duration of DAPT followed by P2Y12 monotherapy. So using this information, we basically take the DAPT guidelines and we just added that little yellow point there that says discontinue aspirin after 1 to 3 months with continued P2Y12 monotherapy as a class 2A in patients with stable ischemic heart disease. So you can either go 6 months of DAPT and followed by stopping the P2Y12 and continuing the aspirin, or you can go 1 to 3 months of DAPT followed by P2Y12 monotherapy. In patients with BMS, we don't have any specific recommendations, but it's the same concept. And in patients with ACS who get a DES, similarly, you can see you can go 12 months of DAPT, or you can go followed by aspirin, or you can go 3 months of DAPT, 1 to 3 months, followed by P2Y12 monotherapy. So let's talk about the recommendations for triple therapy, because now the duration of aspirin is slightly different, and I'd love to hear everybody's input on this. So we looked at the trials that looked at the duration of triple therapy in patients with AFib undergoing PCI. And we gave it a class 1 that in patients who are undergoing PCI and are taking oral anticoagulant therapy, that it's recommended to discontinue the aspirin treatment after 1 to 4 weeks. So here, Mike, it's a shorter duration of aspirin treatment than what we said when it's not triple therapy, when it's not anticoagulant, but it's just P2Y12 monotherapy. And this is for patients specifically who are on triple therapy. This is to reduce the risk of bleeding. And this is based on several trials, and I'm just showing you the Augustus trial, which looked at patients. All of these trials, again, were powered for looking at bleeding events, and they demonstrated significantly lower bleeding with apixaban this is apixaban, but they demonstrated significantly lower bleeding, sorry about this slide, with dual therapy, so apixaban plus a P2Y12 inhibitor compared to apixaban plus a Coumadin plus a P2Y12 inhibitor plus a aspirin. When you look at the pooled data, you can see that MACE is not significantly different whether you do a vitamin K antagonist and DAPT versus a NOAC and a single antiplatelet. But there's definitely a lower risk of bleeding in pooled data with the NOAC and a single antiplatelet. Now, interestingly, in these trials, each of the trials had different endpoints. So some of them like gave the aspirin, just loaded them on the table, and then after the PCI, as Mike, as you sort of indicated, the confusion is that these are trials of anticoagulant therapy, and they stopped the aspirin right after the PCI. Others used longer duration of aspirin, and in Augustus, you can use it up to 2 weeks. It was enrollment, you can be enrolled in the study up to 2 weeks, and the average duration, I think, was 7 days of aspirin. When you take a deep dive into Augustus, when you look at ischemic events, and remember, none of these trials were powered to look at ischemic events, but interestingly, when you look at definite or probable stent thrombosis, the rates were nearly 50% reduced in those patients who continued aspirin compared to those patients who were taken off the aspirin and only on a P2Y12 inhibitor plus a NOAC. While this is not significantly different, it is, really a strong signal. When you look at the timing of stent thrombosis in Augustus, you can see that most of the stent thrombosis occurred early on. So you can see that the differences between the aspirin and the placebo really separated out very early on. And so I would say if you're going to use triple therapy and you have somebody who's a very high ischemic risk and not a very high bleeding risk, you might want to consider, going the full 4 weeks as opposed to stopping after a week or stopping on discharge or whatever.
I agree. I mean, Dominick, what's your feelings? I try and go a month of aspirin if I can.
Yeah, so my take on this is, every patient is obviously different, and Mike, you and I, we had an opportunity to work on the North American consensus, and you try to push it as long as you can. Let's put it this way. The question becomes, what's the ideal stopping time, right? We know that you should never go beyond 1 month, okay? And I think the guidelines got it right between 1 and 4 weeks, although our consensus as well as the European consensus says that the fault is anywhere between discharge and 1 week. So I like to keep everybody at least that 1 week, and then I evaluate at that time point. And every patient is obviously a little bit different. Obviously the complex patients, you want to keep them on up to 4 weeks. If you know the patients at high bleeding risk, probably at that 1 week visit is when you're gonna stop.
I agree. Every patient is an individual decision, individual patient. Neha, your feeling?
Probably have a slightly different take on this as a preventive person. So I'm never the person deciding in the cath lab. If I'm doing my job right, I'm never in the cath lab. So I'm never the person deciding. So it's interesting because I'm getting the person after their PCI and I see wildly different practices. And I get patients from Duke and patients from the area. And again, I see widely different practices. What I have started to see a little more often is that if it seems to me that if the PCI has been particularly complex, it's left main, it's Prox LAD, there's a full metal jacket, I tend to see a month of triple therapy in those patients. And I don't know if that's what all of you do as well. That seems very reasonable to me. But in the absence of that, I've been seeing basically mostly people stop the aspirin pretty much right off the bat.
Interesting. Jacqueline, what are you doing?
Yeah, so I'm sort of I usually like to do 1 to 2 weeks. I mean, I always do it during the hospital stay. And I've had patients who say for whatever reason, I had one person who had amiodarone toxicity, so he was on acute steroids, and then of course you're going to stop on discharge. But for the most part, I like to take them to the 1 week visit. And then I usually then stop it at 1 to 2 weeks. But for sure, if they are not having a high bleeding risk, I like to take it to 2 to 4 weeks. That's my preference.
So you ask 4 cardiologists, you get 4 different answers. That's the way, or 8, Yeah.
One thing to add, Mike, however, is also, a lot may depend also on which P2Y12 inhibitor the patient is on. Now, clopidogrel is the default P2Y12 inhibitor in these patients, but we do have some who may be on one of the more potent agents. And the European guidelines, and actually our former North American recommendations, say if you're on one of the more potent agents, these are the ones who you should be stopping at time of possible discharge.
Yeah, and I stick mostly with clopidogrel, by the way. Well, Jacqueline, take us
Yeah.
through a few of the unanswered questions here.
Yeah, so I think that the biggest unanswered question is, what do we do after that 12-month mark or that 6-month mark? So it's easy with the old DAPT guidelines where you continue DAPT and stop the P2Y12 after 6 months or 12 months or whatever time you're going to stop it. But if you have somebody who you stopped after 3 months, your aspirin, and now you're at the 12-month mark on your ticagrelor, what do we do after that 12-month mark? Do we now go back to aspirin, or do we continue to treat with ticagrelor? And we, as a guideline writing committee, didn't really feel that there was data beyond that in terms of, based on these clinical trials, which were all designed to stop. I mean, global leaders went to 2 years, but for the most part, we're all designed to stop after a set period of time. So when you look at the older guidelines, this is the 2014 guidelines of chronic coronary syndromes, you can see that aspirin use is a class 1 indication, and clopidogrel is reasonable as if you have a contraindication to aspirin for chronic coronary syndrome. So these are people sort of beyond their acute phase of the 1-year mark or whatever.
People often forget there's a patient attached to the stent and they need secondary prevention. And, we really can't forget about that.
Oh yeah, for sure. And, and again, I'd love to ask Dominick about his, I noticed in your consensus statement that you even dropped the aspirin if they're on an anticoagulant after that set period, but we can talk about that later. But I'll tell you that since the recommendations of this chronic coronary syndrome guideline, there's been a lot of more recent data. So this is the DAPT trial looking at gastric erosions with aspirin versus clopidogrel. And these are in patients who had baseline no erosions. And they showed that there was really no difference in the rate of gastric erosions. Many patients did get gastric erosions, but there was no difference in aspirin versus clopidogrel. But certainly if you were on dual therapy compared to monotherapy, there was a higher rate of gastric erosion noted in patients on dual therapy compared to monotherapy. So telling you that definitely the dual therapies are associated with increased gastric erosions.
But to think the other thing on that slide, Jacqueline, go back, look at the number of people, the percent of people with the erosions, 96% with the erosions on clopidogrel. Amazing, right?
Exactly. A large number of people are getting gastric erosion, very interestingly, to some degree. These are people who didn't have it at baseline.
These are where you swallow, this is swallowing the little mini endoscopy pill, right?
Yes, This is that trial. And when you look at the host trial, and I'd take on it, Mike and Dom and Neha, you can see that in the host trial, which was a very large trial, I took over 5,000 patients, they randomized patients to clopidogrel versus aspirin, and they demonstrated that there was a significantly lower event rate in terms of a MACE plus bleeding events with clopidogrel compared to aspirin. Again, this is just standard aspirin, not a phospholipid-coated aspirin. But when you look at bleeding, even major bleeding was significantly lower with clopidogrel compared to aspirin. And yet we don't really know, all of these studies, the host trial included, really weren't done with the phospholipid-coated aspirin. And we know here, and I'm sure Dominick will be discussing it in more detail, this phospholipid aspirin coating really shows that you have less gastroduodenal mucosal damage. So with all of this information, all of these differences in bleeding we're seeing, or differences in mucosal damage, or no difference in mucosal damage between aspirin versus clopidogrel, would it be different if we used a different formulation of aspirin? And the other question I had is, in the host trial, and I'd love your take on it. This was a trial of patients conducted in, I forgot which country, but it was mostly
Korea, I believe.
Population, Korea. Thank you. So the question is these patients are at high risk for gastric malignancies. Is it possible that there was more bleeding with aspirin because we're uncovering more problems because they have a higher risk for gastric malignancies?
And we certainly saw that in the Triton trial, where we had more GI cancers detected in the prasugrel arm, again indicating maybe they're doing a bleeding stress test, right? Jacqueline, that was just spectacular. Maybe, Jacqueline, can I ask you to put your slide back up showing the mechanism of action of
Sure.
some of the more recent formulations? Dominick, maybe you, and we have a little bit of time left here. Maybe you can walk us through some in just a minute there. Go back a slide, Jacqueline.
Yeah, just let me just exit the screen and show. Let me go back to that.
I'm going to have Jacqueline put up the slide of the timing of the absorption of these different molecules. First of all, Dominick, I have a disclosure. I do smooth salting from every major pharmaceutical company that makes antiplatelets, including the manufacturer of this antiphosphatidylcholine complex. Dominick, talk to us a little bit about recent advances and in formulations and where you see the field going.
Sure. So I think the starting point is, asking the question of why the need for newer formulations, and the answer is very simple: to overcome the limitations of currently available formulations. So what are our main concerns about aspirin? Well, the first concern that we know now for decades is a gastrointestinal toxicity, right? Why do we have gastrointestinal toxicity? I say the two main mechanisms. We have a direct mechanism, which is due to the interaction of the acid with the GI mucosa. And the second mechanism is a systemic, which is related to the effects of aspirin on prostaglandins, and obviously the effect on blocking platelets. So the question becomes, can we overcome some of this? Obviously, we cannot overcome the systemic effects because that's what you want aspirin to do. But what about some of the local effects? And that's where enteric coating comes into play. So this has been known for many years, but as nicely shown at the beginning of the presentation today, enteric coating, by definition, is associated with delayed absorption and impaired absorption, which by definition, you take these bad PK principles and it translates into bad PD effects. And this is the reason why even within the label of enteric coating, we have something called erratic absorption, erratic effects. So the question becomes, can we come up with a formulation where you can, on one hand, overcome, at least in part, or improve the GI toxicity, so having something which is more protective, if you will, but at the same time not be limited by the impaired absorption. So in other words, continue to have reliable effects. So two important principles. And this is where the novel complex Vazalore comes into play, which is essentially, it's a capsule and it has a liquid lipid aspirin complex. As you can see here in the cartoon, the capsule essentially dissolves in the stomach, and the liquid lipid aspirin complex then goes downstream into the duodenum, and that's where there's a dissociation at a rising pH of the drug. So what we have learned through pharmacokinetic and pharmacodynamic studies is the drug works like plain aspirin, in other words, a non-enteric coated. So there's immediate absorption, reliable absorption, and a complete COX-1 blockade. Okay, so it works like a plain aspirin. Okay. And there have been a number of endoscopy studies, as shown here in the slide, which also shows a greater safety profile in terms of risk of developing erosions and ulcers. So it does not completely abolish okay? But it's definitely more protective. And this, again, is related to the a specific formulation, which leads to less GI toxicity, okay? I think it's important to underscore that this does not mean that there's no GI side effects, okay? Because we know that aspirin, by definition, needs to exert its systemic effects, right? And so inevitably, once it's absorbed, you're going to have the same impact on prostaglandins and on hemostasis, but definitely is more GI friendly because of its formulation. And because of its formulation, it is not affected by the impaired absorption as a standard enteric coating, which is out there, which is 95% of aspirin that's being utilized in the United States. So hopefully this kind of explains the PK and PD and GI effects of the drug. Now, one thing I would like to highlight, because this came up the last time, is there's a lot of confusion out there with physicians sometimes telling their patients, well, why don't you just take aspirin together with food? Okay. And that's something that we do not want to recommend to our patients, because that further enhances the delayed absorption. And so, having said that, we have also done some studies with Vazalore showing that it is not as impaired with concomitant food intake as shown with enteric-coated aspirin.
So Dominick, you get the speed of regular aspirin and you get the safety of kind of enteric-coated aspirin with this new formulation. I mean, it kind of combines the best of both those. Is that correct?
It combines the best. It combines the best of both worlds. I would say that is fair. Now, obviously, it would be nice to have larger studies. This is better. All the data thus far has been rather consistent definitely from a PK and PD standpoint. There was an earlier slide showing that the effects in diabetics, obese diabetics, we obviously showed the same effect in healthy volunteers. That was with the 325 milligrams. Most recently, we presented at TCT the 81 milligram data, which is obviously what we mostly use in clinical practice, and we're still seeing that same immediate absorption and potent and prompt effects.
Thanks, Dominick. That was spectacular. We do have a question that came up. Is aspirin indicated for people who have who don't have CAD or PAD? So if you're diabetic and you don't have CAD or PAD, is aspirin indicated? That's the question.
I'll have Jacqueline respond since she's the guideline writer.
Guideline writer.
Actually, that's so funny. I was going to defer that to Neha since she's the primary. But
which is an indication of the state of affairs. Yeah.
So our guidelines don't give a recommendation either way, because it's about revasc after PCI. So you have a revascularization indication. But I'm not sure what the new guidelines are coming, because the preventive guidelines are coming,
right,
are currently being underway.
So Neha, what say you?
Yeah, so I mean, essentially, this question seems to be asking about primary prevention in patients with type 2 diabetes. And I think this is where it's very confusing. I think we do have some data like from the Ascend trial, which would suggest that, yes, there is a tiny kind of ischemic benefit from aspirin versus no aspirin. It was like 1.1% absolute risk reduction, but then it was like exactly a 1.1% absolute risk increase for bleeding. So it kind of counterbalances. And there was a couple other Japanese studies. I think TIPS 3 also looked, it was high risk primary prevention looking at aspirin, and there was no real benefit in the subset of patients with diabetes. So it's getting kind of muddier and muddier. We used to recommend that. And now I think if you look at kind of the more recent European guidelines and the ADA guidelines, I think generally we're staying away from just suggesting aspirin in everybody with diabetes. But if you're concerned or they have elevated risk, there's like a lower level recommendation that you could consider it. And again, like Dominick was saying, it needs to be personalized. And we do it based on the patient. But I do think there is a lack of evidence suggesting definitive benefit for aspirin in primary prevention with type 2 diabetes. That
To
sounds
summarize-
good, I think.
Yeah, no, I think that's, I mean, diabetes is essentially a cardiac risk factor, so that makes good sense. Well, I just want to make sure some of the key lessons are for secondary prevention. We're talking secondary prevention, though. It remains a class 1A guideline to give aspirin and, to continue it. None of that has changed with some of the recent guideline revisions. We're still gathering a lot of information. I think we're still learning about the dose. Crazy enough, if your drug's been around forever, still trying to figure out the right way to give it, particularly in obese patients. But I want to thank all of you for joining us here. I couldn't put together a better panel. Neha and Jacqueline joining us. Really great to have guidelines people and preventive people. Dominick, you're such a repository of antiplatelet information. Thanks to all of you for joining us here. Hope you enjoyed our session. Hope you come and join us for our next town hall. Hope to see you soon. Thanks. Bye-bye.